All right. So the first one's a little bit more of a riddle, or a story. All right, helium and hydrogen atom are floating around in space. Helium says to hydrogen, I think I lost my electron. Hydrogen says, are you sure? Helium says, yeah, I'm positive. All right, how about this one? What did the firefly say to his girlfriend? You look simply glorious. Get it? Glorious? All right. Oh! Somebody explain it to your neighbor for me. Okay, so our last lecture, I think all the units have been fascinating, but I particularly like cardiovascular, so I saved it to the end. It'll wrap up our semester, and hopefully you'll find it as interesting as the other units. Okay, tends to be one of my favorite subjects. And so first up, what I want you guys to do is I want you guys to act like an SI. But you're an SI for 202, because all of you have taken 202, right? You did really well. Gloriously well, okay? So I want you to draw a simplified picture of the heart. And I want you to label these 4 components. You can label more. Okay, so if you're doing that, and you're done, some of you are already done. Then I want you to describe with your neighbor the difference between afterload and preload. Or define it. What are they? Some of you laughing at each other's drawings. That's not very good.
Yes, like the heart with the blood that fills up, like the heart needs, like it needs to shoot blood around.
So it's like a little glass and then you push.
What are you guys doing with this? If you need something else to do, now on your drawing, I want you to, with arrows, I want you to demonstrate the directionality of flow of blood through the heart. You might need to draw on some other structures like what? The pulmonary veins, the pulmonary arteries. You might have to put in a couple of valves, right? You might have to put in a bicuspid and a tricuspid valve. This is our review. We always start out with a little bit of review. Everybody got the blood flow? Who's still working? Who's a little more time? Okay. So, who can define, I'm going to turn on the front lights. Who can define preload and afterload for us. Then we'll get to the drawing. Anybody? You go first, you can choose which one you define.
Preload would be, well, I want to say pressure. It's the amount of pressure that the left ventricle has to overcome in order to get blood out into the aorta.
Preload or afterload?
Preload?
So the definition's correct, but it's afterload.
Oh, okay.
Okay? So afterload is the pressure that the left side of the heart has to generate in order to open up what valve? The aortic valve, so that the blood flows out of the left ventricle and into the aorta. Okay? And so the pressure that's in the aorta is what pressure is that that's in the aorta?
It's not your systolic blood pressure?
Yeah, it's blood pressure. It's not your question. Okay? We might describe it different ways. We may call it systemic blood pressure. We may call it mean arterial pressure. MAP. Remember these terms? Okay, we may say that we can measure it during systole or contraction, or we can measure it during diastole, which is relaxation. Okay? But in essence, that pressure in the aorta exerts a force on the aortic valve to close it. So the afterload is the pressure that the heart has to generate to open the valve. Okay, what about preload? What's preload?
Blood that flows into the ventricles.
What's that?
Blood that flows into the left ventricle.
Sort of. Okay? It refers to the filling side of the heart. So it's the right side of the heart. And it really refers to the muscle length of the cardiac myocytes before they contract. So as the heart fills, the ventricle stretches, right? And preload is directly related or proportional to venous return. So if you increase venous return, right, you increase, I'll draw it this way, you increase end diastolic volume, and that causes an increase in preload. Okay? So increasing venous return increases end diastolic volume, and that increases the stretch on the heart as it fills. Remember that? Okay. So let's go to your drawings. How many of you drew a heart that looks like this? Come on, let's see it. Let me see the romantics in the room. Oh, look at that. That's so sweet. Okay? I did too, so I'm with you. Okay? But there's another way that we can do this. Not that this is wrong. Okay, but the heart, our heart is a little bit more exaggerated on the left side. So it kind of looks a little bit more like this. Okay, it looks like a left-handed kindergartner drew it. Okay? I have one of those in my house, so that wasn't like a slam. Okay. Right? Because the left side of the heart is the working side of the heart. Well, an easier way to draw this, because we're about to do some diagrams, might just be a box. How many of you drew a box? Okay? All right. We have our 4 chambers. What chamber's up here? That's the right atrium. What's down here? Right ventricle, left atrium, and left ventricle. Okay? And where does blood flow into the heart? Where? Right atrium. Okay? And it comes in via what? Vena cava. Okay? And you have what? An IVC and an SVC, superior vena cava and an inferior vena cava. Okay, and then from the right atrium, it flows into the right ventricle via what? This is the tricuspid. Okay, and then from the right ventricle, where does it go? Pulmonary what? Pulmonary circuit, and this is what? Pulmonary what? Artery, right? Pulmonary artery, away. And that's deoxygenated blood. Then it goes to the lungs, so we'll say 2 lungs. And then it comes back to the lungs oxygenated in what side? Left side, and specifically pulmonary what? Vein. From lungs. Right, now that's oxygenated blood. You guys following this? And then it comes into the left ventricle via what? Okay, this is the bicuspid, and there's another name for it. What do we call that? Mitral valve. Okay? And then where? The aorta. And what's the valve here? The aortic valve. You guys remember all that? Oh yeah, okay. So, preload is on this side, and afterload is on this side. So that should make sense. Preload is the load the heart sees before it beats. Afterload is the load the heart sees as it's trying to eject blood out. Okay? So if you don't have sort of a concrete understanding of these foundational terms, it makes it difficult to understand the disease state. Especially when we start talking about certain ones that we're going to talk about today. Like congestive heart failure. Because the way the heart pumps and the flow that takes place throughout the heart is critically important. And you can imagine if you have a higher afterload, right? So if mean arterial pressure goes up, what does that do to afterload? If mean arterial pressure goes up, what does that do to afterload? It increases it. High mean arterial pressure, we call that what? Clinically? High blood pressure, okay? But we would use another term, hypertension. Or called high blood pressure. So, a lot of people don't understand why having high blood pressure is a problem. You know, some would say, well, if your blood pressure is high, doesn't that just mean that you're pumping blood faster and harder? Yeah. But it also means that the heart has to work harder. It also means that if you looked at the vascular tree and there was a higher pressure in the vascular tree, do you think that would be less stressful on the endothelium or more stressful? More stressful. So hypertension, we all would probably agree that it's a bad thing. But hopefully that gives you some understanding as to why. Okay, so if hypertension or high blood pressure is present, mean arterial pressure is elevated, that increases afterload. That means the load on the heart to eject blood is higher. So it has to overcome a larger pressure head in order to pump blood out every heart cycle. Okay? We got this? Alright, so today we're going to look at 3 main types of diseases, but there's 4 or 5, how many are there? 1, 2, 3, 4, 5, 6. There's 6 listed on this slide. I could have crammed a few more on there, but the point was to give you some examples of different types of heart disease that account for about 40% of all the deaths in industrialized countries. 40% is from that list. I added up all of those, and it adds to about 40% of all deaths. That's in the industrialized world. That's more than twice the number of deaths by all types of cancers combined. Okay, so cancer is about 20% in industrialized nations compared to 40%. the first three, congestive heart failure, arteriosclerosis, and ischemic heart disease, are the three that we're going to cover in today's lecture. But there are a long list of other types of heart diseases. The other three that we won't cover today help to add up to that 40% of the pie. Okay? But we're going to cover a vast majority of that 40% in CHF, arteriosclerosis, and ischemic heart disease. Both chronic ischemia as well as infarcts, acute infarcts. Okay? So the first one up is congestive heart disease, or what we call congestive heart failure. So what's happening here? Well, the heart itself is having to work against an increase in load or stress. And so it usually means that it fails or it's unable to crank out blood as efficiently as it was before. And so if we look at cardiac output, you guys remember cardiac output is a function of what? You guys remember this formula? Cardiac output equals what? So stroke volume times heart rate is one formula. There's a few. So cardiac output, stroke volume is going to be measured in what? Milliliters per what? Beat. And heart rate is what? Beats per minute. And so the units, the beats cancel. Cardiac output is what? Milliliters per minute. Or it could be converted to liters per minute. So it's the amount or the volume of blood that you're pumping out every minute. Or you could calculate out per second if you wanted to. But it's usually expressed per minute, volume per minute, milliliters or liters per minute. So if you have congestive heart failure, your cardiac output goes down. The amount of blood you pump out every minute is decreased. Imagine what that does to the patient. Think they feel good? No. Can they exercise well? No. Okay. Eventually it could kill them. So what is the cause? Well, the etiologies that are shown here, there's two main ones. One is an endocarditis, which would be an inflammatory disease of the endocardium, where the heart itself becomes diseased, and it becomes inflamed, and it infects the heart. And then the other one that's far more common is an abnormal load, like hypertension. And that's what we see in our patient population mostly is hypertension. High blood pressure, leading to an increase in mean arterial pressure, increasing afterload, the pressure the heart works against, and that causes congestion in the heart, meaning that the fluid builds up there, and you have a forward failure, if you will. Okay? Typically, congestive heart failure, CHF, is systolic in nature, meaning its problem is on contraction events. But it can have diastolic complications as well during relaxation. We'll talk a little bit about that here momentarily. So if we look at congestive heart failure, and we understand these mechanics or this physiology, the physiology is critically important. Understanding the flow, the dynamics that the anatomy allows to happen is important for us to begin this lecture, and that's why I start with that. It's also important to understand how venous return influences end-diastolic volume and how that increases preload on this side or the right side of the heart. And we'll get to that here in a minute. Because we're going to be able to separate out left-sided heart failure versus right-sided heart failure. Okay? And they have unique problems associated with them. Now, when the heart starts to work against the load, okay, when cardiac muscle essentially increases weight training, meaning it increases its load, what do you think, how do you think it responds? Let me ask it a different way. When skeletal muscle exercises against increasing loads, what does it do? Okay, there's a term for that. Hypertrophy. Okay? We're at the end of the semester, so now I want you guys to start talking like you're taking the class. Okay? Hypertrophy. You get hypertrophy of skeletal muscle when you load it. Right? That's why you go to the gym. Okay? So you can, look all gnarly. Now, cardiac muscle striates, so it does the same thing. Right? So it's going to respond with a hypertrophic response, just like skeletal muscle. Well, there are some other adaptations that take place I'm going to talk about here. The heart is going to try to compensate. Early on in heart failure, the heart will release norepinephrine. Norepinephrine is a sympathomimetic neurotransmitter, right? So it elevates the sympathetic nervous system, and it increases the contractility. It increases the contractility of the heart, so the heart beats more forcefully. So in this situation, if there's a load coming back on the heart that's higher, and it beats more aggressively, it's able to push out more blood flow per unit time. But the problem is that's a short-term solution, because slowly over time what happens is that causes an increase in peripheral resistance. Right? Peripheral resistance. In the systemic tree, the vessels will constrict, and that increases the resistance of the vasculature, and over time that's a bad thing, because if you increase total peripheral resistance, what do you do to venous return? If you increase total peripheral resistance, what do you do to venous return? Over time, it goes down. So if you lower venous return and you have less blood coming in, what happens for output? Do you guys remember Frank Starling's law of the heart? If you put less in, you get what? Less out. If you put more into the heart, you get more out. So the compensatory mechanism of norepinephrine release is a short-term solution for a long-term problem. Okay? And what is the time frame there? Well, it could be a fix for days, months, to maybe a year. And then the patient will start to slide again and demonstrate declining heart performance. Okay? Secondarily, you stimulate the Renin-Angiotensin system. Right? The Renin-Angiotensin system, and some of the pathways are shown here on the slide. You can kind of remind yourself that angiotensin 1 goes to angiotensin 2, and there's an enzyme known as angiotensin converting enzyme that facilitates that reaction. And the whole point of this renin-angiotensin network is to do what? What does renin-angiotensin do? The system. When you upregulate renin release by the kidneys. What's that? What do you do? Increase blood pressure. So you conserve water, right? Think back to our kidney section in 202, when you're talking about urinalysis, right? You're talking about urine production. So the renin-angiotensin system conserves water, so you don't urinate and lose as much water. You bring it back to the vasculature, and that increases blood volume. If you increase blood volume, you increase what? If you increase the volume of the blood, do you increase venous return? Yes. If you have higher venous return coming into the heart, what do you do to cardiac output? It also goes up, right? Momentarily. So higher venous return equals higher cardiac output early on. But the problem is, you guys just nailed it, is long term, if you stimulate renin-angiotensin system, you increase blood volume, and that causes what to pressure? An increase in blood pressure. So months to years later, when hypertension is present, what does that do to the afterload back on the heart? elevates afterload. Is that a problem for this failing heart in the next 2 to 5 to 10 years? Yes. So our secondary compensatory mechanism is a short-term fix as well with long-term problems. So the first one, norepinephrine release, gets you days, months, maybe to a year. The Renin-Angiotensin System might take you beyond that first year. But now the patient is really sliding. Now the third thing that happens is the only really beneficial thing that doesn't have a long-term side effect. But it a lot of times isn't enough. So there are what we call natriuretic peptides, or atrial natriuretic peptide, ANP. It's released from the atrium, and it's released from the right atrium to cause activity on the kidney to increase urine production. So this atrial natriuretic peptide is released by the right atrium in response to an increase in stretch. Well, when would the right atrium detect an increase in stretch? Under what conditions? What's that? Give me some physiology answers. When would the right atrium be experiencing an increase in stretch? An increase in preload, okay? And the preload would increase because of why? Why would preload go up in these patients?
Increase in afterload.
Well, not quite to afterload.
Is it because of an increase in blood volume?
It's an increase in blood volume. The increase in blood volume is causing high blood pressure or hypertension. That's causing an increase in mean arterial pressure, which causes an increase in afterload. But this direction, the blood volume that's high is going back to the heart. You with me? And so as the blood volume is high coming back to the heart, that increases the stretch. And so what the heart says is, blood volume's too high, I need to get rid of some fluid. And what's the fastest way to do that? Urinate. Okay? So atrial natriuretic peptide stimulates what we call natriuresis, which is the release of sodium at the level of the kidney. Water likes to follow sodium, so you excrete more water in your urine. You have more dilute urine because you put sodium out there in the collecting duct and water follows it. So you have a condition of natriuresis and diuresis. Okay? So the ANP is actually one of the 3 longer-term solutions that the body uses to maybe keep a patient somewhat stable, if you will, having hypertension for years, and their heart failure never worsens, kind of plateaus off. Then they start to slide again. And then we come in, and believe it or not, we treat one of our favorite drugs to treat with early on for heart failure is what? Any guesses? It has to do with this last mechanism we just talked about. Patients that are in sliding heart failure, their heart failure is progressively getting worse. They're in chronic heart failure, it's progressively getting worse. We prescribe diuretics. Diuretics mimic what ANP does, and the patients urinate quite frequently, lowers their blood volume. It also is very effective at lowering their blood pressure. And so what a patient on diuretic will complain of is when the heart kind of backs up with fluid, a lot of this fluid backs up into the lungs. And so the lungs become congested with fluid, and it's hard to breathe. So after treatment with diuretics, the patient pees a lot, volume goes down, it clears up the lungs quite a bit. They can breathe more easily at night when they're sleeping. But then they complain that they have to get up and go to the bathroom like 3 or 4 times. Okay? So diuretics are very, very effective at treating heart failure. Okay, so let's break this down a little bit. And I had already alluded to Frank-Starling law of the heart. So Frank-Starling law of the heart is more that comes in leads to more output, right? So if you increase venous return, you get an increase in cardiac output. And the Frank-Starling law of the heart as applies to heart failure is first you compensate. You compensate by modifying things on the incoming side to influence the output due to Frank-Starling's law, because what goes in is going to affect what comes out. But Frank-Starling's law of the heart also says that if you start influencing the output, eventually you'll decompensate because it'll make its way over to the right side, or the inflow side of the heart. Okay, so these compensatory mechanisms only last so long, and then the patient continues to fail and progress. Congestive heart failure, it's also referred to as chronic heart failure, is not reversible. So the patient, the best case scenario is the patient will stabilize or plateau for a number of years before they start declining again. But they will always decline. They won't have a recovery phase. Okay, they won't have a recovery phase. What ends up happening is these patients progress over time. Let's say a patient that's been in heart failure for 10, 20, 30 years. Okay, they're probably on a transplant list, waiting for a donor heart. And the hypertrophy that takes place, the enlargement of the heart, because the heart is working harder over time. That means that the heart, every minute, is exercising at a greater rate than yours and mine. And so it's almost as if they're chronically exercising. So what we see is we see severe weight loss in these long-term patients because of the metabolic demand that the heart has to try to keep up with the output. So for example, if you need to maintain a certain level of cardiac output to survive, and your volume per beat goes down, the only way to compensate is to raise the number of beats per minute. Okay, so it's not uncommon for them to have a higher heart rate. Well, if they have a higher heart rate, they're exercising, they're using more energy. So this terminology of cardiac cassia, this is this body wasting that takes place. And we see cassia happen, weight loss is what that word means. But it's a heart-derived weight loss. It's not because they're exercising in the gym or they're on some fad diet. It's because their heart is working harder than it really needs to. So if we look at heart failure to this point, now we're going to start to separate out. We're going to look at left-sided versus right-sided. Because there are things that can happen on the left side of the heart that are independently different than things that happen on the right side of the heart. The causes of left-sided heart failure are things like ischemic heart disease. So the blood flow that goes to the heart comes right off of the atrium, or the aorta. Right off of the aorta, you've got an ostium that comes back and actually perfuses the myocardium of the heart itself. Well, if we have atherosclerotic disease that we're going to talk about later this afternoon, then we could decrease the blood flow that goes to the heart, and the heart becomes ischemic. If the heart becomes ischemic, then you have areas that are underperfused and are not working as well. Okay, so it's not able to beat or function as a pump like it's supposed to. You could have systemic hypertension, right? Systemic hypertension, this is what we drew over here. There's an increase in mean arterial pressure, that's going to increase afterload. We have either mitral or aortic valve disease. Well, if you have a leaky aortic valve, or if you have a leaky mitral valve, this valve is supposed to shut during diastole. If it doesn't shut well and it kind of leaks back, then you get some regurgitation that takes place in relaxation, and now you have inefficiency. You have fluid that's sitting in here that was supposed to be ejected out that's now leaking back. Okay, so over time, a bad mitral valve or a bad aortic valve could lead to left-sided failure. Or you could have primary myocardial disease that could be like a genetic type of disorder, okay, where the myocardium itself is affected. So what's the morphology? What do we see? Classically, left-sided heart failure, we see an enlarged heart, hypertrophic heart. We see a dilated out ventricle. It enlarges itself. The chamber here blows out. Okay? We see pulmonary congestion and edema. So when we drew this, if we back up to the lungs via the pulmonary vein, because if this mean arterial pressure is too high, and now you get flow back this direction, or fluid stuck here, or if you have a leaky valve here, it backs up this direction, where does it end up? In the lungs. Okay, so you get a lot of fluid collecting in the lungs because it's not being pushed out into the system. So the biggest impact clinically on these patients with left-sided heart failure, which is the more common of the two, is the pulmonary circuit. There's a lot of fluid, edema, and pressure within the lungs. It's hard to breathe. That's why we call it congestive heart failure. Patients are struggling to try to get a deep breath. As soon as you give them a diuretic and you decrease blood volume, they have this relief, this feel of, oh, I can actually take a deep breath. And that's what these patients will say is, it's really hard to take a deep breath. I feel like I can't get a really good breath. I'm kind of, my breathing is very shallow. That's the feeling. Okay. If we look at the symptoms, they're going to have symptoms of shortness of breath, dyspnea. They'll have a cough, a persistent cough. And that's because there's fluid in the lungs, so it's kind of irritating the lungs, causing them to cough. They'll have shortness of breath while they're lying down, while they're sleeping, which can be annoying. Very, very uncomfortable. They'll have tachycardia. Why do they have an increase in heart rate, tachycardia? What formula would you point to that would explain why the heart rate? This one right here, right? We already described it. If cardiac output goes down, and it's going down because stroke volume is decreasing, the only way to increase cardiac output is to raise your heart rate. So these patients classically run fast. Okay, so they're tachycardic. They'll have mitral regurgitation and even atrial fib. So the mitral valves are bicuspid, so they get a lot of regurgitation that you can actually hear it with a stethoscope. You can actually hear the gurgling back on diastole that you shouldn't be hearing when you're actually listening in. Okay? And in many cases, they'll have atrial fib because the atrium are detecting pressures that they're not supposed to be detecting. They're detecting a back pressure, and so it kind of disrupts the Purkinje network. It disrupts that electrical signal that happens throughout the heart. Okay. I see some of you testing yourself to see if you have left-sided heart failure. I got some heart rate tests going on back there. That's good. Awareness is good. I hope in this class you guys are young enough where you're not going to be exhibiting symptoms yet. Yeah.
For the cough, is it going to be?
No, it's not a productive cough at all. Because the fluid isn't in the respiratory side. It's on the vascular side. Does that make sense? So they feel like they need to cough like when you have a chest cold, right? When you have a chest cold and you're like, oh, that was a good one, right? You feel like you want to bring fluid up, but nothing comes up. So it's very annoying because patients are very familiar with that feeling of, I've got stuff in my lungs, but it's in the vascular, in the tissue side. It's not trapped in the respiratory tree. So bringing it up, there's nothing there. That's open. Okay?
Is hypertension play a factor?
Hypo?
Yeah.
Low blood pressure?
Yeah.
No. Low blood pressure is very, very healthy as long as you're being perfused. Right? You might run cold. Right? Your toes are always cold, your hands are always cold, but hypotension is usually fine as long as you're getting enough blood flow. If we look at contrasting this to right-sided heart failure, we can see that the most common cause of right-sided heart failure, so that's the left side. You can see that the cause of left-sided is going to be a lot of things that influence back pressure or afterload. And that backs up the left side to the lungs. Well, if it progresses from left side, it backs up to the lungs, what can it affect? The right side. So the most common cause of right-sided heart failure is left-sided heart failure. Okay, and now these patients with right-sided heart failure are in a really bad situation. Their heart is not going to be working for many more years. Okay? So they'll have, if you have lots of pulmonary congestion in the lungs here, then that means that the left side has failed, and that's backing up to the right side. There are some other less common causes of right-sided heart failure, like diseases of the lung tissue itself. Okay, there are cases where patients could have right-sided heart failure that's independent of left-sided effects because they have a lung disease. There's something that's attacking the lungs, causing a lot of fluid to be in the lung, independent of what's going on the left side of the heart. Okay, so those would be lung parenchymal diseases. Well, so pneumonia usually is short in duration, but things like bronchiectasis or things like scarring that takes place with asbestos contamination. So those would be traumas to the lungs that would take place that are independent of what's going on the left side of the heart. Okay? But a patient that gets pneumonia, it could be problematic if they got pneumonia for 3 to 4 months every year for the last 10 years. Well, maybe so. But usually people are going to go, see the doctor, figure out what's going on. Okay? There could be some other less common lung vascular diseases that can cause problems on the lung tissue side. So these would be vascular diseases where the vessels themselves in the lung become very leaky, and so they let a lot of fluid out into the extracellular space, and now that fluid is there putting back pressure on the right side of the heart. Again, the other causes are far fewer. The biggest cause of right-sided is left-sided heart failure. But the impact is going to be on the system. So the backup that comes to the vena cava on the venous circulation is our biggest issue. And so you're going to see congestion in the liver, right? You're going to see a lot of pleural effusions around the lungs. You'll see a lot of peripheral edema, swelling of the feet and of the lower extremities, because the venous return isn't coming back from the inferior vena cava, and so you get a lot of distal blood pooling that's taking place. So the biggest impact on the right side for right-sided heart failure is on the systemic circuit. You're going to see enlargement. That's what that hepatomegaly is an enlargement of the liver. So left-sided heart failure may lead to right-sided heart failure owing to or because of what? A, excessive volume retention. B, poor perfusion of the right coronary. That's the circulation of the heart itself. C, increased right ventricular afterload. Or D, arterial hypotension. There's your hypotension. What is it? A, B, C, or D? C. What is increased right ventricular afterload? What would be the afterload? Is the terminology we used over here on the left ventricle. What would be the synonym to that? The right ventricle afterload. Where would that load be coming from? From what tissues? From the lungs, right? So if the lungs back up with fluid, that's the load that comes back onto the right ventricle. Did you guys follow that? Okay, so that's the comparator, if you will. So that's heart failure. Heart failure is very, very common in our country, in the Western world. You're going to see more and more of it clinically. Okay, and one of the biggest problems is because we have vascular issues. And when we have vascular issues or damage, that leads to problems with hypertension. Okay? If we have damaged vasculature, we increase our risk of developing hypertension. In addition to that, it's a catch-22, because if you have hypertension, you've just increased the risk of damaging your vasculature. Okay, so they go hand in hand. So you want to keep the blood vessels healthy. Question?
I'm sorry, it was a little earlier on. So you're talking about the afterload, the increased afterload into the right ventricle. So afterload is what's coming out of the left ventricle. So you're saying it's coming back to the right ventricle?
So afterload, classically, is referred to as what happens on the left ventricle. That's the load on the heart to inject blood. Okay?
It's just ejecting back in on itself, is basically what's happening?
With afterload?
You're saying, because you said it's an increased afterload in the right ventricle.
Right, so let me just follow this. So afterload here on the left side, right? Afterload here on the left side is influenced by mean arterial pressure. Afterload on the right side is influenced by the pressure that happens in the lungs. You with me?
Yeah.
Because if the right ventricle needs to inject blood to the lungs, the lung pressure has to be low. If the lung pressure goes up, then the right ventricle has to work harder to get the blood into the lungs.
Okay, I understand.
Does that make sense? So it's just like what happens over here, but it's talking about it on the right side. Okay? All right, so our second disease is going to be arteriolosclerosis. This is vessel damage. And so we want to talk about what happens with vessel damage. And how does a vessel get damaged? Well, this is very similar to all other types of healing that we've looked at this semester. We're going to see an inflammatory response. Okay, we're going to see macrophages coming into the area. We're going to see a fibrotic response. We're going to see extracellular matrix coming in and being laid down. So up top is a normal blood vessel. A healthy blood vessel, to remind us. This is a cross-section. So the top layer is our endothelial monolayer. Tell me some of the features of that layer. What does it do? What are some of the characteristics of the endothelium?
Elastic?
It's elastic, so it can actually stretch. It's stuck to a basement membrane that's elastic. What else?
Capable of recruiting white blood cells.
Capable of recruiting white blood cells, agreed. What does it do in a normal situation where there's no disease or damage? What's that?
It's like slippery.
Slippery? Okay, it is actually. If you've ever felt the inside of a blood vessel, it's really slick. It's shiny, it's glistening. Okay? It's antithrombogenic. You guys remember that? So the endothelium are an antithrombogenic layer. They release substances that prevent the blood from clotting, which makes sense. So if you have a spot where there's no endothelium, then you're going to stimulate clotting. Because the clotting cascade, platelets are activated by collagen. And the basement membrane that endotheliums sit on is collagen. So if you lose an endothelium, or an endothelial cell, underneath it is the activator to activate clotting of platelets. Makes sense, because if an endothelial cell shears off, that means you have damage, most likely, and you want to stop the leak of blood. Okay? So they're antithrombogenic, and they also have vasodilating capabilities. Remember, they release substances known as nitric oxide. So being able to dilate out a blood vessel and open up the lumen diameter keeps it nice and patent. That's a word that means open, patent, P-A-T-E-N-T. Okay? So right underneath the endothelium layer is this internal elastic lamina. This is this layer that is made up of elastin. It's very, very stretchy. And then from this internal elastic lamina to the external, that's the border of where you see the tunica media. Remember, tunica is just a word that means coats. So this is the middle layer, or the media layer. internal layer, and then the outer layer, the adventitial layer, tunica adventitia, is beyond that external elastic lamina. This is where you'll see blood vessels, you'll see extracellular matrix. The endothelium that sit here prevent these smooth muscle cells from proliferating and migrating into their space. The endothelium are very well behaved. They like to exist in an orderly fashion of a single layer of cells. The smooth muscle cells like to grow and proliferate, but they won't grow beyond the borders. But if the borders are disrupted, they'll continue to grow. Okay? So look at what happens in disease. So here's a progression. If you've got endothelium that have been compromised, you're going to get smooth muscle cells that move into this intimal layer where there aren't supposed to be any smooth muscle cells, and they start proliferating. Those smooth muscle cells become very mitotic, meaning they increase their division. They secrete all sorts of extracellular matrix, and you can see evidence of that in this picture here on the far right. That causes that middle layer to thicken. And those smooth muscle cells are non-contractile. They don't behave like normal smooth muscle cells. So if I have a tube and I'm looking at it down the center, and I'm thickening my intimal layer slowly over time, what am I doing to the diameter of the tube over time? It's getting smaller and smaller and smaller. Does that make sense? If that happens throughout the body, what happens to mean arterial pressure? It goes up. If you don't believe me, go home this afternoon and turn on your garden hose. Okay? And then squeeze the hose down, right? While you turn it on and hold it away, and then it's gonna fall right here. And then I want you to slowly squeeze the diameter of the hose and keep looking at it. And you'll see that pressure will go up, right? Or you can do it the other way at your roommate to see if they believe you. Okay? So imagine this disease process happening throughout the whole body. Right? What happens globally to blood pressure? We become hypertensive. Over 40, 50 years of this slow narrowing that takes place. You guys understanding what I'm talking about? Not only that, but if you've lost endothelium and you have a more narrow tube, are you more likely to have a clot? Absolutely. Okay? So, as this vessel has the opportunity to become damaged and diseased, we have a couple different categories. We have abnormal thickening and hardening of the vessels, just like what we described. This is broadly referred to as arteriosclerosis. Now, we have two subtypes of arteriosclerosis, and they're spelled uniquely different. And it's important for you to understand the difference between the two. Now, the first one, arteriolosclerosis, you see the extra LO in the middle here? Arteriolosclerosis, this one is commonly associated with hypertension, like what we've been talking about. And it targets really mostly the small arteries and arterioles. The one that, this is more of the silent one. The silent one, arteriolosclerosis. The one that is more propagated in the literature is atherosclerosis. And this one forms a plaque lesion, or an atheroma. And this is the one where we often hear about when we're looking at angiograms. Angiograms are x-rays of the heart when you've injected a contrast agent. I'm going to show you a couple after the break. And we see the narrowing of the vessel in a certain area. In like a very focal area, we see it. The arteriolosclerosis is the one that's happening all over the body systematically. But the atheromas take place maybe in certain focal spots. Okay? If that focal spot happens to be the heart or the carotids, now the patient's at risk of developing a heart attack or a stroke. Okay? But slowly over time, all of our vessels will start to narrow. Okay? Because we're subject to things throughout our lifetime that cause slight damage to that endothelial lining. Now, the atheroma is the one that's more interesting to look at because we see this big lesion. Okay? The arteriolosclerosis with the hypertension, that looks more like this previous slide, where we sort of get this slow narrowing that takes place over time. But our atheroma that develops is kind of cool. The atheroma, the AS that we're going to talk about, you get this thickening, and then you develop what we call a necrotic center. That necrotic center has foam cells. Foam cells are macrophages, and they're very close to the blood flow, so they can get in there very easily. These are macrophages that are ingesting lipid. And so they're denoted by these macrophage-like cells that have these yellow lipid dots inside, because that's all the lipid that they've actually consumed with phagocytosis. And they also have cell debris that they've taken in. Okay? Question?
Would that cause bulging within the vessel?
Would that cause what?
Bulging?
Well, it's bulging inwards. Okay? It's bulging inwards in the sense that the outer layer of the vessel is intact, but the inner lining is starting to close off. And so you'll get asymmetric lesions. So if I look at a blood vessel like this, okay, to answer your question, let's pretend that this blood vessel, here's my tunica intima. And it usually looks like a black squiggly line because it's elastic in nature, so it stays black. Okay? So this would be a normal vessel. And with this atherosclerosis, you'll see something like that. Okay? And you'll see all of this area in here that's debris. And you'll probably see a zone right in the middle that's actually dead tissue, necrotic center. So if you're, the bulging, yeah, but it bulges this way, in. It doesn't bulge out, that would be an aneurysm. Okay? So, how does this happen? What's the pathogenesis of atherosclerosis? AS, as we abbreviate it. Multiple steps. There's an ongoing response to an inflammatory insult. Ongoing meaning chronic, over time. The endothelium that normally is supposed to be anti-thrombogenic, okay, and it's supposed to be able to allow for vasodilation of the vessel, no longer does that. And now what ends up happening is you start to accumulate in this lesion fat, lipoprotein. Okay? And you get a fibrous scar. And then you start getting cholesterol that deposits there. And you'll get calcium that deposits. In fact, in my lab, on many occasions we'll get cadaveric samples that come in. Because we're trying to look at different types of devices to treat different types of lesions. And so one of the devices that we use, that we investigate, is what's called a crossing catheter. So the way this thing works is, you can imagine this drawing that I've drawn. What happens if this starts to look like what if this starts to, oops, wrong marker. What if this starts to do this? And this lesion expands, and so it covers this whole zone. Can you guys appreciate that? So we would say that that little lumen, like moon-shaped sliver, we would say that that vessel, we're looking in cross-section, we would say that that's probably 90% occluded. Okay, and let's say that's in a critical location. That's down at the femoral artery. And now blood flow to the distal extremities is being compromised. So what they might do is they might come in with a catheter, come in here and try to break through that lesion, chew it up. Okay, so we call these crossing catheters. You want to cross the lesion. And if it's 90%, you could potentially wiggle it through this little gap right here or up here. Okay, put it all the way across the lesion, and then activate the catheter with energy to try to break this up. Okay, radio frequency or heat energy, microwave energy. Another technique is you roto-rooter it, right? You come in with a catheter that spins like this, and it chews through here like, you know, one of those little drill type of things. These are real devices. Okay, so when we're trying to evaluate these devices in the lab, these companies are always wanting to know, well, how hard is it? It's like, it's really hard. So I need to know an actual value. So we'll get cadaver samples, right? We'll explant them, and they're like this. They're pretty fresh. And we'll take a scalpel, and on a 90% occlusion lesion, the lesion might be that long in the femoral artery. And if I take a fresh razor blade and I cut through it, if I cut through it this way, and you look at the razor blade, the edge of the razor blade looks like this, where I cut through the lesion. So to cut through a segment of like 6 inches takes like 4 or 5 razor blades to fillet it longitudinally. And we're throwing those in the sharps container because they're breaking off, they're fracked. Okay, so then we open up the vessel, and you can feel how hard it is. It's crunchy, it feels like stone. So we've gone a step further. We've actually measured the hardness. You can measure hardness by putting a force transducer on a substance. So you remember, if you put a force transducer on this table, it'll give me a hardness value. The force that it takes to depress versus on my hand, softer, right? So we looked at all sorts of different materials. We looked at plaster of Paris. We looked at pumice stone. You guys know what a pumice stone is? It's like you use it to clean your heel or whatever. Okay, or maybe your bathtub. Okay. We went to the butcher shop and got cow femur. Okay. Cut the cow femur and got cortical and trabeculated bone. Okay. These lesions that we're talking about here have the same hardness value as pumice stone, as cortical bone. That's how hard they're, like cutting through rock. And that's what develops in our bodies in these atherosclerotic lesions. Okay? Yes, question?
If you do manage to break through one of those lesions, I assume that everything is still damaged, so it'll grow back. How long is that going to take?
Yeah, so that's a great question. If you get through the lesion, the statement is, isn't the endothelium still damaged? Yes. So how long does it take for it to grow back? Well, it'll re-stenose within a year if you don't put something there. So you usually put a stent in place to hold it open, or a stent graft is even better. Okay? So that's what's going on clinically. Let's talk about some of these steps here, and then we'll take a break. Well, you can see that, look at the list of things that cause chronic endothelial injury. The things that are going to stimulate damage to the endothelial cell. Now, not all of them are going to be familiar to us, but let's look at the ones that I want you to kind of think about. Hyperlipidemia. What's that word mean? Too much fat in the diet, right? In the bloodstream. So hyperlipidemia, if you have too much fat floating in the bloodstream, that causes endothelial damage. Hypertension, right? We talked about hypertension. Smoking. Smoking has a lot of toxins in it, and those toxins cause endothelial damage directly. Let's see, some of these toxins and viruses that we might be exposed to in our lifetime can actually cause endothelial damage. So there's a long list here. I just wanted to focus on those for this particular lecture. But once we damage them, then we start seeing a loss of function. If we see a loss of function, we see this little monocyte able to squeeze through. We see how this endothelium is no longer continuous. There's a big gap here because we've damaged it. You allow for monocytes to extravasate out, but they don't move into the tissue. They move into the blood vessel wall itself. Macrophages get there, and those macrophages stimulate that inflammatory response that we've learned about all semester. So they start chewing things up, breaking down debris, okay? The smooth muscle cells that move into the area, they're recruited by many of the growth factors that the macrophages release. These macrophages release growth factors that cause stimulant activity of the smooth muscle cell to come in and replicate. So as this happens, you start creating these free radicals in the area because of the macrophages. You get oxidation of the fat that's present. So low-density lipoproteins are actually oxidized. As they're oxidized in that location, they become more permanent fixtures. And the macrophages can't get rid of them as well. The infiltrate into the intima that takes place is the macrophages, and they come in and start chewing up and cleaning up the debris. The stuff that they can consume, the lipid that they're able to consume, turns them into foam cells. And those are these cells that have the yellow large debris within them. You recruit new platelets into the area to try to close off this wound or this lesion. And all along this time, the smooth muscle cells are continuing to be recruited. As they're being recruited, they're proliferating and laying down new matrix. And you continue to accumulate new lipid debris, and this atheroma grows. Atheroma is a word that means gruel. That's what it translates to. Gruel. So it's kind of like a lesion that is a gruel-like or a gross-looking lesion, to be quite honest. So if we look at the steps that take place in a different slide, showing really some of the same things. This is a normal vessel on the left, and this is an atherosclerotic plaque development on the right. Here is our internal elastic lamina, right here. So what's supposed to be on the other side of the internal elastic lamina is just our intima. And you can see as this progresses to the right, time progression from normal vessel on the left to diseased vessel on the right, we get all this infiltration of macrophages becoming foam cells, smooth muscle cells moving into the area, and they're not supposed to even be present, and then proliferating, laying down new extracellular matrix, which is a fibrotic scar. And this level here versus this level here, this is closing off the lumen of the blood vessel, right? So you get this fatty streak that forms because of all of this debris, a fatty streak within the wall of the blood vessel. And it hardens over time. It hardens over time because of the oxidation that takes place because the macrophages are present. You form this fibrous plaque, and in this fibrous plaque, you have trapped what's called C-reactive protein. This is a protein in the blood that circulates around, and it's raises in presence, or it's elevated during times of inflammation. So we see this getting trapped in this particular area. Now this plaque could form a stable plaque, which means that it's going to continue to grow and close off over time, or it can become what we say unstable. And this is what was being asked about a little bit earlier. So an unstable plaque is one that is hard but brittle, and if it's pressurized, it's at risk of what? Rupturing. So if it ruptures, then you have an aneurysm, like what was asked about earlier. So an unstable plaque is at risk of rupturing and becoming what we call a complicated plaque. complicated because it's presenting now new clinical problems, like what would be found in aneurysm. So the last slide before the break that I want to show is this histology. And I just want you to appreciate what it is that we're talking about. So this is a cross-section through a blood vessel like what I was trying to draw. And this is the lumen, L, labeled L. That lumen used to be this entire segment. So this would say, how occluded or blocked would you call this clinically if you saw that? 60% occluded? Okay. Yeah, I'd probably say, 60, 62.5, something like that. I like to use, pretty accurate numbers. I mean, they can come see you, or they came see me, they can get a really accurate number, like 62.5, 297. So here, this lumen used to be this entire size. Let's zoom in. Let's zoom in at the level. This black squiggly line is that internal elastic lamina. I'm sorry, this is the external elastic lamina that's being shown here. And the internal elastic lamina is now following this line up top. Okay? If we zoom in this, do you see all of the, in panel B, do you see all of the yellow? All of that yellow stain? What do you think that yellow stain is? Those are all foam cells. Okay, so that's all trapped fat within macrophages. If you look at panel C, you can start seeing some calcification, which is the arrowheads. Calcification, which is the arrowheads, like this right here. So that's a hard calcified lesion. That's what cut and caused damage to our scalpel blades. Our razor blades were being cut by all of these calcified lesions. All of the arrows are pointing to new blood vessels. Neovascularization. Why does the lesion itself have to neovascularize? Why does the lesion itself have to neovascularize? What's that? It's an inflammatory reaction, number one. So you're getting inflammatory mediators coming in, they're releasing neovascular agents. But as this tissue is growing, it needs to supply itself with a blood flow, otherwise it becomes necrotic. That's one of the reasons you get this necrotic core, is if the blood vessels don't develop fast enough within the lesion itself, then the middle of it goes necrotic. Kind of like what we saw with cancer, remember that? So it's very common for cancer tumors to become very angiogenic. Same kind of issue that's going on here. All right, let's take a break and we'll pick it up right here. I'll tell you the good news afterwards. Okay, so have a healthy snack.
Okay, that's not happening. And then I got the right I know, and then my friend Zach, he's in my histology class.
That's from our class.
I was like, no, I walked right out. I was like, yeah, did you not see that line?